One. There we go.
Hi
Okay.
guys, this is our presentation for evidence-based practice. We decided to do our presentation on the use of IV acetaminophen in post-operative patients. This is by Adriana Clark, Teresa Silva, Wendy Teppel, and Cheryl Wagner. Okay, so on average, Americans undergo 9.2 surgeries throughout their lifetime. Many of these patients suffer from pain after surgery. 20 to 40% of patients complain of severe postoperative pain. Many studies have been done to assess the efficacy of IV acetaminophen use postoperative in patients for pain relief. So our clinical question is, does the administration of intravenous acetaminophen decrease the amount of narcotics needed to control pain in postoperative patients? The purpose of this is to discover whether or not postoperative use of IV acetaminophen decreases the amount of narcotics used postoperatively for pain control. So the key stakeholders here are patients. This provides data, and these are the patients are affected by the research. Registered nurses are the ones that directly provide care to the patients. They assess pain levels, administer medications. Surgeons and physicians administer and order perioperative medications, and the nurse managers and nurse directors, they manage and oversee patient safety and patient satisfaction. And then the systemic search for research and evidence. Initially, we determined the research topic and the clinical question. We identified the purpose. We conducted the search for data. Our primary sources were articles. We used Chenal, we used PubMed, and we used Medline. And then we reviewed the abstracts. We utilized the relevant articles and sources. We eliminated the ones that weren't relevant to our search, to our question. And then we critiqued each source and synthesized the summaries.
Hello, my name is Cheryl, and I'll be presenting the grading the evidence portion. We used the grade model, which was used to rate the level of evidence for these studies using high, moderate, low, and very low. A high grade would mean that further research is unlikely to change our confidence in the estimate of effect. A moderate level would be that further research is likely to have an important impact on our confidence in the estimate of effect and may change the estimate. Low grade would be that further research is very likely to have an important impact on our confidence in the estimate of effect and is likely to change the estimate. And very low means that any estimate of effect is very uncertain. Criteria for grading types of evidence. Randomized trials start with a 3, which is the highest one. Observational studies start with a 2, and any other evidence starts with a 1. Randomized is considered high level, observation low, and any other evidence very low. Other criteria for grading using this model is you will decrease the grade if limitations to study quality are serious or very serious. If there is an important inconsistency, you decrease the grade as well. If there's any uncertainty about directness, you decrease the grade, -1 some and -2 for major. Imprecise or sparse data, you take away 1 point, and high probability of reporting bias, you take away 1 point. There's also increased criteria. If there's strong evidence of association, you increase it by 1 point. If there's a very strong evidence of association, you increase it by 2 points. If the evidence of dose-response gradient is present, you increase it by 1 point. And if all plausible co-founders would have a reduced effect, you increase it by 1 point. So we went ahead and used this model to grade the evidence. For the study by Alchazar, the design was a randomized control trial, so it started out high with a high grade. There were some limitations, but not serious. For instance, they didn't record pain control beyond 24 hours. No inconsistencies were noted. It was very direct and precise and focused, and no biases were identified. The strength of association evidence was associated but not strong, so we didn't add any points for that. For the study by Hansen, it was considered a retrospective analysis, which is very low to start out with. Limitations included co-founding factors, non-randomized sample. We took away a point for that. No inconsistencies noted. It was direct, precise, and focused. No biases identified. And it had a very strong evidence of association with a 95% confidence interval for decreased length of stay and lower hospitalization costs. So we added a couple points for that. The study by Song was a retrospective analysis. So it started out with low grading. Different anesthesiologists administered the medication. It also relied heavily on subjective documentation and no data on pain after 24 hours. So those combined factors, we took away a point for limitations. Inconsistencies, some inconsistencies with caregivers was noted, but not significant enough to deduct any points for that. It was direct, precise, and focused. No biases were noted, and a strong evidence of association between IV acetaminophen, decreased length of stay, and faster return to bowel function was found. So we added a point for strong evidence of association. The study by Null was a randomized control trial, which started out with a high grade. Limitations included VAS scores on activity not assessed, relatively small population. We didn't consider that a significant limitation. No inconsistencies were noted. The study was direct, precise, and focused. No biases were detected, and a strong evidence of association between the use of IV acetaminophen, the reduction of post-op fentanyl use, and reduced post-op nausea and vomiting was found. We added a point for that. The study by Ziolkowski was a systematic review of the literature. So it started out with very low grading. There was a small sample size, but that was not significant enough to lose points there. No inconsistencies were noted. It was direct, precise, focused, no biases identified, and strong evidence of association with improvement to ambulation time was identified, so we added a point there. So altogether, the first study did not go up and down in points. It stayed the same. Second study, we deducted one for the limitations, but then added one for very strong evidence of association. We added two, actually, for very strong evidence of association. Ended up at a 2. Article 3, one was deducted because of the limitations, and then one was added for the strong evidence of association. Article 4 had strong evidence of association, which was added to its strong score. Article 5 started out very low, but there was a strong evidence of association, which brought that up a notch. So we went ahead and just averaged all of the articles to come up with our overall grade, which ended up at 2.4, which was considered by this model moderate to low. Further research is very likely to have an important impact on our confidence in the estimate of effect, and may or is likely to change the estimate. So existing evidence-based practice of using opioid analgesia as monotherapy for post-op pain is challenged using the Iowa model. The Iowa model includes triggers, either problem or knowledge focused, which serve as catalysts for nurses to search and evaluate the existing scientific evidence. Next, changes to improve practice are implemented when substantiated by a sufficient research knowledge base. Finally, the effects of practice changes upon selected outcomes are monitored over time in order to facilitate the changes and provide a feedback mechanism. Triggers to initiate change. The triggers were identified as post-op side effects to opioids, hospital costs associated with opioid analgesia, length of stay associated with the use of opioid analgesia. Changes to improve practice included gathering research articles, comparing opioid analgesia monotherapy to adjunct use of IV acetaminophen. The effects on practice, monitoring outcomes in the clinical setting by gathering information from charts, questionnaires, and real-time patient interactions.
Okay, so now we're going to be talking about the synthesis of research. We used several articles to find out whether IV acetaminophen has been previously studied and its efficacy in pain relief and decreasing opioid consumption. The first article that we're looking at is an article by Elchar et al. The main research question is IV acetaminophen use prove more economical for hospitals? And does it have an effect on patient satisfaction and length of stay? And basically what was found is that the main, the very poor pain control is reported with bariatric surgery, and the administration of IV acetaminophen had fewer patients presenting the ER after discharge. So it does suggest that there is more efficacy in using IV acetaminophen when the patients go home. This was a level 2 evidence, as it was a randomized controlled study. The next article we're going to discuss is Gonzalez et al. And they discussed, does IV acetaminophen affect opioid consumption in bariatric surgery patients? This was a retrospective analysis. And what it found was the group who received acetaminophen perioperatively had a mean daily opioid dose of 99.5 compared to those who didn't receive it, who had a 164.6 milligram dose. This was a level 4 evidence, as it was just a retrospective analysis. Our next article discusses, does combining acetaminophen with IV opioids reduce the length of stays in hospital costs in orthopedic surgery patients versus just using opioid therapy? This was also a retrospective analysis, and they found that IV acetaminophen and opioids is associated with statistically significant shorter hospital stays compared to just using opioids monotherapy. This again was a level 4 research article because it was a retrospective analysis. All right, our next article is Unal, and they discussed, does IV preemptive acetaminophen have an effect on postoperative pain scores, pain satisfaction, fentanyl consumption, and the incidence of fentanyl-related side effects? This was a prospective randomized study, and what they found was that cumulative fentanyl doses for 24 hours after surgery was higher in the fentanyl group than it was for the patients receiving IV acetaminophen as well. And they also found that nausea and vomiting scores in the early postoperative period were found to be higher in the fentanyl group. This was a more reliable article, as it was a level 2 evidence because of a randomized controlled study. This next article with the Zalowski, it discusses, does scheduled IV acetaminophen for pain control in the first 48 hours after surgery decrease opioid use and result in earlier bowel movements for patients? It was a systematic review of literature, and what it found was the data analysis revealed significant improvement time in ambulation for patients who received IV acetaminophen therapy. And their overall opioid use was decreased between the time for the first bowel movement and time to general diet. And this was a level 4 evidence, so it had strong evidence, but it was low reliability. And the sixth article that we've used was an article by Song, and they asked, what are the effects of IV acetaminophen on opioid consumption in patients undergoing laparoscopic bariatric surgery? They used a retrospective chart review. Patients receiving, and the results were patients receiving IV acetaminophen have in the combined group, so they received both IV acetaminophen and opioids, had a lower cumulative opioid consumption than patients that did not utilize acetaminophen. And this is a level 5 evidence because it was evidence from systematic reviews of descriptive studies. And so based on these articles, our literature suggests that IV acetaminophen can reduce the amount of narcotics used by postoperative patients. So studies should be conducted to determine the effectiveness of acetaminophen in controlling pain in postoperative patients and reducing narcotics consumption. The study should also assess effectiveness of the IV acetaminophen, side effects of the IV acetaminophen compared with opioids, its effects on length of stay, and costs to the hospital.
So the proposed guidelines, we use the PDSA model. And so the plan part of that was based on literature review to create a retrospective study and establish inclusion criteria of surgical patients from a specific hospital and include data from surgery time up to 48 hours post-operatively. Exclusion criteria included spinal anesthesia, peripheral nerve blocks, a pre-op diagnosis of chronic pain, and anyone under the age of 18 years. We created 3 groups of patients. Group A is to be a control group without any IV acetaminophen. Group B would be patients that only received a single dose of IV acetaminophen. And then Group C would be the patients that received more than 1 dose of the IV acetaminophen. So continuing the PDSA, for the do part, we would audit 4 weeks of charts in a single hospital for every postoperative inpatient that fits the inclusion criteria. Then we would study, for the study part, we would analyze and organize data collected. And for ACT, based on reevaluation and the data collection, we would inform the stakeholders of the IV acetaminophen efficacy in reducing narcotic use or reveal that it lacked its lack of diminishing narcotic use in postoperative patients. So the proposed evaluation plan, for data collection, we would select appropriate subjects based on our inclusion and exclusion criteria. We would audit charts using forms to collect the specified data. We would convert the total opioids given to morphine equivalents for ease of comparison, so we could compare oranges to oranges and apples to apples, as well as converting the pain scales to a pain number equivalent, also for ease of comparison. For the analysis, the comparisons would be made between groups A, B, and C, and we would utilize analysis of variance. Reporting, we would report the data to our stakeholders, as stated before, and then we could publish any data relevant to the nursing profession. So in conclusion, the narcotics and opioids may have many known adverse side effects on postoperative patients, and non-narcotic analgesics can speed recovery while minimizing those adverse side effects. Utilization of IV acetaminophen in controlling postoperative pain in patients is worth considering and should be administered even when ordered PRN. For future implications, further research into the use of all types of non-narcotic analgesics to facilitate adequate pain control after surgery, and also to change the hospital culture to embrace the addition of narcotic adjuncts like IV acetaminophen. Here's Appendix A that has our audit form on it, as well as Appendix B, Appendix C as well. And here are our references.